Good morning and welcome back to Dashboard Dissections Cosmetic Surgery Edition. So we're headed up for a long drive today, and it's another dreary, gloomy. Actually, that bit of sky looks nice, but it's quite gray, I will say. Wow, we are rhyming. Okay, that is enough of that. So today, what shall we discuss? So last week we talked about tightening of the skin. So I guess now we can talk about what to do when that doesn't work. And so usually, as I said in that episode, it requires excision of the skin, which usually means a larger scar, which is what people are trying to avoid most of the time when they do a tightening procedure like Body Tight or Morpheus. But common areas that we end up excising skin are lower abdomen, which would be a tummy tuck, which I do have an episode about tummy tucks and the different types. And then brachioplasty for the arms, which I guess I haven't really discussed. And then in the neck, a neck and facelift can be necessary if Face Tight and Accutite don't help as much as you hope they will, or fillers, which I do also have an episode about facelifts. So I guess we could talk about arms and thighs, because thighs are the other place that I use it, which anyone who's come to me at all about anything legs, even my own staff who ask me about it, I will be the first person to tell you that legs suck. Operating on them is difficult in a cosmetic way. Operating on them is difficult. The skin is very different. So anyway, let me start over. Thigh lifts. There are two different types. There's a medial and a vertical. And basically what that means is medial is sort of in the crease between thigh and vagina. And that is the incision, is at that crease. And it mainly affects the upper portion of the thigh, that excess skin, that kind of crepey, falling skin that women get and deal with. And so it basically excises a crescent skin, a crescent moon shape of skin in order to get that thigh skin to tighten up. But that really only helps the upper 1/3 of the thigh. If there's more excess skin in the middle or lower down by the knee thigh, then you have to do what's called a vertical. Sometimes you need both, and that can be a real doozy. So this is really common in patients who have had massive weight loss. They have a lot of excess skin, not a lot of fat, and it can sort of drape and hang like crepey, and people really hate that, especially when they like to wear shorts and skirts, etc. And as we age, that upper knee area tends to really bother people because even if you wear longer shorts, that area is visible. So that is the reason that thigh lifts are kind of coming back into our repertoire. But they suck for me and for the patient. They're really hard to heal from. The legs, they swell like crazy. And they don't heal as quickly as the rest of the body. So I tell patients, if we're doing liposuction of areas and the legs, I tell them you're going to notice a difference in the rest of the body, maybe in like 2 to 3 months. Final result won't be until like 6 months. But you are not going to see a difference in your legs for at least 6 months. And a lot of it is just the lymphatic drainage of the legs is different. There's only one way in and out. Well, maybe not in, but there's only one way out. And it can be affected. Actually, lymphedema is a side effect of a medial thigh lift because it can affect the lymphatic drainage of the leg. That's also one of the reasons that we curve the abdominal incision of a tummy tuck the way that we do, is to avoid the lymphatic drainage of the leg. Now, is it common? No, but it can happen. And lymphedema is awful. Actually, my stepsister just texted me about being concerned that she might have lymphedema. And it can affect anyone. It is super, super rare. It's usually more likely when you've had a surgery or some intervention that could have affected the lymphatic drainage. Because as we've talked about before, the lymphatic system is it's a very delicate system. That's the word I was looking for. It's a very delicate system that doesn't like to be manipulated at all, other than massaging it, but it doesn't like to be anywhere near surgery. So it can be really difficult. And for patients who already are self-conscious about their legs, the risk of causing lymphedema by trying to make their legs look better, that's a big deal. And a lot of people don't really discuss it because it is a super rare side effect. But if it happens to you, it doesn't matter if it's like a 1 in 100,000 risk, you're the one. So that always sucks. But anyway, all that to say, it takes forever for legs to heal. It takes forever for the swelling to go down in legs. So it can take a very long time for that swelling to go away because they're gravity dependent. And, you know, like I said, that lymphatic drainage, there's kind of one way out. And it can take a long time for that drainage to take effect. So, and also I think compressing that area is difficult. Because if you're compressing the thigh, then you're affecting the calf drainage. And you also don't want to compress the thigh too much because that, like I said, will cause your foot, ankle, and calf to swell up. So then it's like, do you wear compression all the way down? There's a lot to it. So it's a difficult recovery. The results are, you know, the liposuction of the legs, the results are usually not good because what we end up worrying about is excess skin of the thigh leading to needing a thigh lift. And people who are doing liposuction usually don't want a scar, a big scar. And I get that. Nobody really wants those things. But anyway, medial thigh lift makes you get an incision in that crease between thigh and vagina, and we cut out that crescent skin area or that crescent moon shape of skin. Man, I did it again. Oops, I did it again. Love you, Brittany. Anyway, we are a squirrel today. Then what you have to do is, in order to make sure that the skin doesn't fall and drape again, you have to really tack that skin up nice and tight to the fascia of the pelvis. It's not really the fascia of the pelvis. Anyway, you want to get a very deep bite, is the point. Otherwise, the skin can be nice and tight, but it'll sort of start to hang like crepey skin again, and that's what we're trying to avoid. So you have to get a really nice deep bite of the fascia in order to keep that skin from falling with gravity. So that's a really painful stitch. It usually does involve some component of the pelvis. And so then movement after surgery is very important. It's very good. It helps decrease swelling. It helps get your body healing. But it can affect that stitch. And that stitch can be kind of painful as well. And it's kind of right in the crease between thigh and pelvis, shockingly. So recovery is hard. That area of the incision, you can't get wet for a couple of weeks, which, you know, that's tough. Especially, you're not going to do just one side, right? I mean, no one does that. So, I mean, I feel like you can smell what I'm stepping in there, that you kind of can't wash that area. That would be hard. Anyway, and then not only that, but then you have to deal with wound healing. It's in a very, very mobile area. This is similar for arms too. I don't feel it's quite as bad because you can sort of move around without moving your arms. You can't really do that without moving your legs. Because walking is really the only form of exercise I allow for most surgeries. Breast implants is a little bit different, but like for tummy tucks, for big scars, for anything like that with a bigger incision, other than lipo. I guess lipo and implants are the only two things that I'll allow you to kind of do more. But walking is really what I tell people to do to stay active during their recovery. And with your incision being right in that crease, it's probably really uncomfortable to walk, I would imagine. Never had it, but I can only imagine that would be not so cool. So that's difficult about the recovery as well. The widening of the scar can happen. Granted, it's not a very visible scar. It's usually pretty well hidden. But, it can be not the prettiest scar. The vertical is less difficult, shall we say, for both you and I. The vertical is really more like a brachioplasty. It really and truly is get the excess skin out, sew it all back together. Now that scar you are going to see. Now I try to hide it in that middle portion of the leg so that way it's, not just like on top of your thigh, because that would be weird, but it is still going to be visible, similar to a brachioplasty scar, but there's not that like deep stitch that you have to get, the risk of like things falling like it does in the medial thighplasty. That isn't really there. And the risk of lymphedema is not as high with that. So a vertical is technically easier, and the recovery is probably easier as well, because it's not right in that crease where the leg mobility is happening. It's sort of just on the inner thigh, and you can just kind of John Wayne walk your way around that. Boy, I'm aging myself in this podcast. Yikes. I can't think of anyone else. John Wayne walk is all I can think of. But anyway, yeah, that's the main way to get rid of excess skin when tightening procedures don't work. So those are two ways to affect the thigh. I haven't done much of like a skin excision from the calf because that area isn't usually as affected as the upper thigh. Similar for the arms, like for a brachioplasty, I have done forearm skin excisions, but again, it's usually not as affected, and the scar is usually less tolerated because it's much more visible in like everything you wear. So when I do a brachioplasty, which is an arm excess skin excision, I basically start my incision at the elbow and carry that up on the inner portion of the arm, up into the armpit, and then down a little bit onto the chest, basically just to avoid a dog ear in your armpit, because that can be really annoying. It is kind of nice. I remove some of the hair-bearing area of the armpit, so that's cool. A little free laser hair treatment, if you know what I mean. Not really, but whatever. So with the arms and with the thigh, I guess if I'm doing not the medial, but if I'm doing a vertical thighplasty, I will do a little bit of liposuction. If I'm doing a brachioplasty, I will do a little bit of liposuction as well. And the main reason I do that is because that, A, helps debulk a lot of the tissue. It also, B, helps kind of separate all the important stuff, all the nerves and blood vessels to the arm and hand or to the leg and foot, kind of pushes all that down, makes the fat cell layer a little bit bigger, and just kind of separates things out. It also helps numb that area pretty nicely, and it helps decrease a lot of bleeding as well. Sorry, spit was going around these braces, man. This journey, I'm ready for it to be over. I feel like they look so straight, like I'm just ready. I'm ready for them to come off. I've had enough. Thank you. This is enough character development for me with the braces. I'm good. I would like my retainer now. Thank you very much. Anyway, brachioplasty. I do a little bit of liposuction to help push all the important stuff away from my surgical field, and so that I can excise the skin. I was actually talking with another surgeon this week, and there's a new technique that, it's not really new. There's an old technique making a reemergence in brachioplasty that's called, wait for it, an avulsion brachioplasty. It's exactly what it sounds like. You just take the skin, you make your incision, and rip. Now, there are some people who are like major believers in this technique who feel that it helps decrease swelling and bleeding. Now, I think if you've done the correct anesthetic, meaning similar to what I do, it's called tumescent anesthesia, similar to what I do for liposuction. So utilizing that anesthetic technique could help. And while I think it probably does have minimal like bleeding and swelling in surgery, I can only imagine once. Now, I have done it once, but it was not a cosmetic procedure. This was a medically necessary procedure to excise the skin of the arm. And it was for an infection. Anyway, so we ended up not closing the incision. We did a wound vac, but I digress. So I did do an avulsion technique basically because the patient was not doing well. And at that point, you need to get out of the operating room to get back to the ICU to try to get them better. So I basically did just rip the skin off, cut it off, put a wound vac on it. And actually, I'm pretty sure I put the wound vac on later. I think I just packed it in the OR and got her out. Anyway, I digress. So people who believe in this technique, like I said, feel as though it decreases swelling and bleeding. My concern in the aesthetic elective world is that what happens when you're out of the operating room and their blood pressure goes back up and you've done no coagulation with the bovie, with our electrocautery. You've just ripped everything open. That worries me a little. I'm sure it's fine because the body is a great machine and it will do what it does, but I can't imagine that is less traumatic than cauterizing as I go. Now, maybe I'm wrong. I guess, some arguments could be made that the heat and that byproduct of the electrocautery is worse because it does cause more of a delayed injury. So it's either you get delayed bleeding or delayed injury. So, I'm not really sure. Not really sure which one is better. I guess I'll try to look into it. More homework from my podcast. So anyway, a brachioplasty, I take the excess skin and sew it back up together. I do usually leave a drain for that procedure. I don't with the thighs, mainly because I don't really feel like it helps in the thighs. And the main reason I do in the arms is just because that area, as it swells, there's less space for things to go, and it can be more problematic on my incision in my head. The drain that I use in a brachioplasty is basically just one that keeps the tract open to allow fluid to drain out. It's called a Penrose drain. I describe it to patients as like a large, flimsy yellow straw. It doesn't have a bulb. It doesn't collect anything. It gives fluid a track to follow that's easy to come out of the body and not sit in my surgical area. But similar to liposuction, I create a dead space that the body wants to fill with fluid. So I do recommend for both of these procedures, thigh and arm, wearing compression 24/7 for a minimum of 8 weeks. At that point, I usually tell you that the more you wear your compression, the better. I recommend at least 12 hours a day, so either during the day or at night, whatever works best for you with your lifestyle. But I do recommend continuing to do that for another 3 to 4 months after that initial 2-month period to help decrease any swelling. For the legs, I'm much more adamant about the more the better with the legs because of that persistent swelling. I usually tell you just to wear it almost all the time, as much as you can tolerate, for 6 months, because that's how long it's going to take for your darn legs to stop swelling. They suck, y'all. They really do. And I wish there was a better option because I have so many patients that don't like their legs. The other thing that happens in legs, especially on the posterior, the back part of the leg, is cellulite. I get so many questions about doing liposuction to help cellulite. That actually is worse. So what cellulite is it's a tissue band that pulls the skin to some deeper structure, which is usually like muscle fascia or sometimes even deeper. But if I were to do liposuction, it's just going to make that cellulitic pattern more obvious. Not always, but usually it does, because again, it's similar to my cantaloupe analogy, where taking some of the fat out of that area might help, but you're going to have all these areas of tethering, and it's that tether that's the problem. Now, there have been some techniques that have come out. Aveli is the one that I know of, and I have done it. And I did it on a staff member of mine, and I didn't feel like the results were that good. Her recovery was awful. I mean, she bruised like crazy. And this woman is tough. She's had a lot of procedures. She said this was one of the worst recoveries she'd ever had. The most discomfort, the most bruising, the most swelling. She hated it. And like I said, it'd be one thing if the results were great, but they were not that good. And it just doesn't seem worth it to me to go through all of that for not a great result. And I have this guy who's just sitting in the left lane again. So, I mean, like I said, if it gave you a great result, it would maybe be worth that kind of recovery, but the results were not that great. The recovery was rough. It's a very traumatic procedure, because it literally is, what's that kind of knife that like you hit the button and like a little blade comes out? It's almost like I hate to say it like this, but it's almost like a very small guillotine. So it's basically the Avelli is this little probe that goes under the skin, and it has this little like hook on the end. And what you're supposed to do is go under the skin and hook the band. And when you hook it, you're supposed to pull on it a little bit and see the skin move with you hooking that band. Okay? Then it has this little guillotine thing. That's probably the wrong device. It doesn't just like, it goes out and like cuts. It's like the Grim Reaper sword. I don't know how to describe it, but the knife goes up, comes out, and then cuts down, so that whatever you've hooked, in theory, should be cut. Okay? But one area of cellulite can have like 4 to 5 bands pulling it down. So you have to be just kind of going around in that area, find it, hatchet saw it, whatever it is, guillotine cut it, Grim Reaper sword it, and you're just kind of blindly throwing a Grim Reaper sword around it just under the skin in that like fatty dermis layer. Actually, it's subdermal fat layer. That makes me very nervous. And like I said, my one patient had some terrible bruising, not great results. And I've had multiple reps come and show me pictures and everything. I just don't feel like it's good enough yet. The minute I do, trust me, whoever can figure out how to effectively treat cellulite, they're gonna be okay. They're gonna be doing great. They're gonna do great things, because that is a huge complaint. And like I said, liposuction actually can make it worse. It can make it more obvious because it takes away that structural support, that kind of pillowiness of the skin, and it will just kind of hang and sag, and trust me, it won't look very good. I can confirm. I have seen someone try to do that and doesn't look good. So we've really gone from skin tightening to skin excision to cellulite. What a time to be alive. Now, I've thought about body tight on cellulite, but again, I don't think it's going to really work. It's that band that's the problem, and it's not really going to break that band. Liposuction does do some band breaking, but those cellulitic bands are rough, and the scarring from breaking that band is just going to create new problems, in my opinion. So again, the technology isn't quite there yet, in my opinion, but I think we'll find a way. I hope, because it is a big problem that a lot of women and some men really struggle with. But excess skin, as of now, the treatment is to cut it out. Unfortunately, I don't see that one changing. I guess I don't really, because that would mean I'm out of a job, but I wish for everyone's sake that there was a better option with less scarring, but unfortunately there's really not. The only way to get rid of excess skin is to cut it out. So I guess the good news, what I usually tell patients is, if you really, really, really want to avoid the scar, then we can try for liposuction and plus minus body tight, face tight, whatever. We can even do a second round of body tight, face tight to see if that helps. That way you can really tell yourself you tried everything. And sometimes it is just that, mental. And, that's important too. I would hate for someone to go through a surgery and be like, yeah, it looks great, but like, what if? What if something had helped? What if something else was an option? We can try it. We can certainly try it. Like I said, the entirety of my job is to give my patients information so that they can make the decision that is best for them. That's all I want to do. I always have patients say, well, what do you think I need? Again, it doesn't really matter. It doesn't matter what I think. It matters what you think. And it matters what's going to help you feel more comfortable in your skin. That's the end all be all of my entire job. I can tell you technically what I can and cannot do and or fix, and I can tell you how we can get there and what options we have, what the risks, what the benefits, what the differences are, and that's it. That's my whole job. From there, it's up to you. And I'm there to help you every step of the way for you to say, well, what about this? What about this aspect of my life? And we'll figure it out together. But that is the entirety of my job, is to give you information. Again, these technologies are great on the right person, in the right location. They can have a great result. But that's true for just about anything, but that's especially true for something like a skin tightening procedure with this kind of technology. So sometimes I will say to you, I don't think this is a good idea, but we can talk it through. And if that's how you want to proceed, that's what we will do. But sometimes things are just a little too far gone that I'll tell you, I think you're throwing your money down the drain, and you're gonna take all that risk, and you're gonna do all that recovery, and you're not gonna like the end result. And I could be wrong. It's happened once or twice, but that's the risk. That's the big risk. And my whole thing is, if we do that and you say, Dr. LaFoon, I hear you, but I want to try this, it's going to help me feel like I tried everything before I went to this large scar, then absolutely. Then at the end of the recovery, if you're like, you know what, it's not exactly what I wanted, I think we're going to have to do what I was trying to avoid, that's okay. That's okay too. We'll get there, but I would hate for you, my big fear, the thing I'm constantly trying to avoid is you coming in at 2 months saying, well, Dr. LaFoon, if I had known that this was going to happen, I wouldn't have done it. That's my biggest fear. I would hate for that to happen. Bad things happen, 100%. That's part of surgery, and that's part of the life that I chose. But, I don't ever want it to be a surprise or a shock to you that something like that occurred. I want you to say, Dr. LaFoon, you mentioned this. We had hoped it wasn't going to be me, but it is. How do we get through it? Now, I'm sure in the moment, no one is going to respond like that, right? I get it. I'm going to be upset too, trust me, if we have a complication. But that's my goal, is for you to say, yeah, you did. You told me this could happen, and here we are. And then we'll get through that too. Well, that turned a little philosophical. I'm going to step down off my soapbox now. This has just become my little soapbox, me screaming into the void of my empty car into the internet. But it's fun. All right, well, I will see y'all next week, and we'll talk about something equally fun. All right, see you next week.